Welcome to NP's Changing Practice. I'm Dr. Carol Berger, and today we're joined by Adina Rey, a family nurse practitioner, and we're going to talk a little bit about her journey. Welcome, Adina.
Hi, Carol. Thank you for having me.
So, Adina, we're going to just talk a little bit about our transition, your first job. Tell us a little bit about the first job that you got as an NP right out of, you were in ICU, right? Your background as an RN was mainly in the ICU at the time?
Yes, all I worked as an RN was in critical care ICU
So
background.
really comfortable with actually pretty autonomous, if any place in the hospital, an RN is very able to, work with it, kind of institute things and, get whatever you needed to get done without having to talk to the doctor about everything, right?
Right. There were a lot of what they called standing orders, which gave you a lot of freedom to use judgment for different scenarios, from blood sugar to heart rates, titrating medications on your own. You didn't have to get an order every time.
And you were comfortable with a lot of those critical situations.
I was.
What medicines to grab, if their blood pressure was tanking, or if they went into really AFib, or, any of that kind of stuff. You were comfortable with that.
Yes.
And so you thought, when you took this role, you got a job right out of school and worked in the hospital, which for me, I did too. So we have that in common. I didn't have critical care background, so when they were tanking, I was looking for the rapid response team. Oh. And that was like, my heart was going, oh no, what do I do, right? But you were comfortable in that situation. So how was your transition to that?
I would say I was comfortable in that situation when working bedside, but I also felt like I had a lot more support at that time. Also, it was an ICU. I wasn't calling anybody else to come and run the code. We just took care of it right there and had everything we needed. But stepping into a hospitalist role, it definitely appealed to me because of my background and loving critical care. So dealing with some of the more acute patients appealed to me. But changing roles initially, it was a little bit of a shock, and more than I anticipated.
So tell us a little bit about that transition.
Well, I started in kind of a nocturnist position, working a night shift, but that meant I was the only one from my practice that was on for the entire hospital. And I started in a smaller community hospital. When I worked bedside nursing, I was at the large university setting, Big Barns downtown. And when I started as a hospitalist, it was a smaller community hospital setting, but there were intensivists on, and then there was me and the ER physicians, and that was it for providers in the hospital. So stepping into that there were a lot of things with it being the first job, just taking on that new role and the amount of responsibility that you felt, it
really is a mantle. All of a sudden you feel the weight of that mantle. And I don't think we really thought as RNs, and I don't know how to explain, because there's a lot of times students, and that's our primary audience right now. As a student, if you've been an RN for a long time, you really think you're just extending the knowledge you already have. And you do have a ton of knowledge and a ton of experience, but there's no way to prepare you for that change. There's nothing I can say, because you aren't a provider and you don't think like a provider and you haven't thought like a provider.
It's true. When you're sitting back in the RN position, it's easy to think about what you think should be done or what you think you would recommend, but it's different when all the responsibility of that decision solely on you to make that decision. So then you find yourself questioning things, and you also do things like you mentioned, you think just broader. There's a lot of things that come into play.
Well, you're not just dealing with one acute problem either. Now, in your case, I think the people who hired you think, well, the emergency room doctor saw the person first. They've done all the testing. Everything is nice and laid out. All you really have to do is just pull it all together in a nice little note in a package for them in the morning, right? And
if only it was that easy.
Not true. It's not.
And sometimes what they have if they have tidied things up and figured out what's wrong, sometimes that is not what turns out to be wrong.
Right,
You know, so that's in their short assessment, and they figured out that the patient is unstable enough that they need to be admitted, and they think these are the reason why, but it's not a complete workup at that point. And there's more information that comes in. Sometimes it's a completely different problem altogether.
Yeah. And so you, as that person, again, I admire you for stepping into that role without having somebody right there to grab. I mean, I know you could go talk to the intensivist, and depending on your relationship with that particular doctor, they're not in charge of you. So that would be like, you know, them just kind of doing you a favor to consult with them, right? Or you could wake up your provider. Mm-hmm. Which none of us want to do. No, I've done it.
I was a big believer in just developing relationships. There were times that I tried to develop a good relationship with all of the intensivists, and I felt comfortable going and asking questions if I needed to. I also developed a relationship with all the ER physicians.
Right.
You know, and if I needed to call and wake up my collaborative physician, then I woke up my collaborative physician. And in the beginning, that certainly happened.
Yeah, yeah.
Or, and I would say after a year, that rarely happened. But there are times I had to call the consulting physicians too that are not my collaborators. They weren't always as gracious about it, but there are times that they had to get calls in the middle of the night also.
Yeah, and you had to say, look, I've got the situation going on, and you are brand new at all of this, right? You know,
yes.
And so you, I'm sure, as I did, learned to function more independently. I worked 2 years as a hospitalist, and I didn't work at night. I did the daytime rounds, and I found that they split the patients up, and I thought initially, well, I'm a new NP, so they're going to give me, you know, the lighter, easier patients to take care of, right? And that's just not how it really shook out. I mean, I think they tried, but they pretty much just split everybody up, and you had what you had. I had the benefit of having them there to be able to, you know, ask questions if I needed to, but they had their own list of people they needed to see too. So it was, you know, I learned how to be autonomous is what I did.
Right. And I think that's what they expected. They didn't want to seem like you felt like you needed a lighter load than they had, and they wanted you to be able to carry on independently. And I had great collaborators. I could go to them with any questions I ever had. I will say this, though, I think also the respect was there because I would investigate it first. I didn't just go and just keep asking questions and questions. I'm never afraid to ask a question, but I would investigate first and come to them with educated questions.
What was some of your techniques as far as how did you investigate everything? Where did you start?
I love up to date, but sometimes up to date is pretty extensive. And so in the beginning, I liked, when I was on the working in the hospitalist role, I really liked the full version of Hippocrates. I know there's a free version that's just the medications, but the full version is comparable to up to date, but it's more concise format. And so that is what I relied heavily on, you know, instead of 10 pages on the subject, it's concise. What you need to know at that moment.
For medicines and what dosages and, you know, what the best treatments, Hippocrates is a lot easier. And they have the interaction checker, which really helps. You know, I always tell my students to make sure you get familiar with Hippocrates. You know, and I'm like you, I like the full version of it too, if I'm working steadily. But for the students, I just want them to download the free version so they can get used to looking up drugs and checking against adverse drug reactions, things that you wouldn't even think about.
And I think Hippocrates is affordable. I think for a year, it might be $180 a year. Up to date's a few hundred.
Yeah, as students, they get half price off, but it's still, but a lot of institutions now do have up to date.
Yeah.
I know Barnes still does, and I think Mercy does. I'm not sure. I think SSM does, but I haven't been there in a while.
Yes.
So a lot of them do have it so that they can get used to looking things up there. it's just a great resource, a great tool to be able to use. So jumping into that, then you kind of, after a while, got recruited by one of the not collaborators, but one of the consultants that, specialists. They said, oh, we like you, Adina, we'd like you to work with us. And you had a couple of experiences, one not as good as the other, but tell us a little bit about what that was like in private practice.
I will say that the first experience that wasn't as good as the other was also a learning opportunity. So when I talk about how hard things were in the hospitalist role, not expecting all of the work and the acuity and research that would go into the hours going into it in the hospitalist, I did come away a better provider because of that experience. And so my first private practice experience, it was not a mesh with the collaborating physician. But that experience, I came away with a better understanding of contracts, a better negotiator, a better understanding of what's important to me as a provider. And so going into a job, what to ask and what to make sure was going to be a fit, And
right,
so,
and you want to make sure there is a good fit there. You really
absolutely.
That provider that you're going to be working with is that person you have to feel comfortable going to, asking questions, and you need to find out how open are they to, having you give them a call or text, how responsive are they? All of those things,
right.
The right contract, because whatever you negotiate, I found this, whatever your contract usually starts at is where it stays for a while. It doesn't it's not like in the hospital where you get reviewed every 6 months and you can renegotiate it. Sometimes it just kind of stays there.
Right. Sometimes it's a couple of years that you're in that contract. And so I think that is very, very important. And sometimes you don't know until you work with the provider.
Right.
Sometimes you're interviewing for a job, and especially if it's one of your first jobs, you may not have had any experience with them. But I do warn people that if there's not a good fit or there's anything ethically that's not meshing, that it's your license.
Right.
And you need to be in a position that you're comfortable and protect yourself. And so I learned a lot of that from that experience. So then my second position was with a pulmonary sleep medicine as outpatient. And it was with my collaborators were physicians I had met in the hospital, had a great relationship to start with, felt comfortable with, had better negotiating skills. So,
we're happier with your contract and with what they needed you to do.
Right. And was able to negotiate the job, and even things with hours or CMEs or things like that you learn to negotiate too, because a lot of these are corporations and their bottom line, they're looking at that. So if they can give you a low figure and get you to take it, then that would be their preference. So you have to be able to learn those skills. And that's something also as an RN I had never had experience with, but in a key role, it's an important skill to develop.
Well, we as an RN never thought about having to earn our wage. We were paid whatever they paid us, and we knew we were worth whatever we thought we were getting hourly. But now we had to bring in the income to pay our salary. It wasn't just, that's a whole new concept. It's like you're now a generator of income and you have to generate your worth. And our first job as a hospitalist with that first company really taught you how, because your bonuses were structured off of, you learned what RVUs were and how much each bill was, for each person you saw at different levels. And then all of the expenses, they would subtract every expense away from what you brought in.
Absolutely.
Everything down to the cell phone.
Everything that you thought was a benefit, we give you these benefits, but it came out of that bottom line. And this is something that I wish as we're going through our graduate or doctoral program, I wish there was a little more that touched upon that. The education focuses a lot on getting you prepared for your boards, but none of RVU, I didn't know what that meant, learning that business side of it, or how to negotiate, or that business side. I wish I'd have gotten a little more experience on that, but that's not, you don't have that experience when you come out, and it's just learning.
You don't really understand that. And I really stress documentation in our classes. I think from the time they hear me from the very beginning, I'm always saying there's a SOAP note and there's an order for a reason. You know, it's all attached to that bill, and how many things that you're able, that's the complexity of care. You're showing it in your documentation. And you know, there's two ways. You can either become a provider who doesn't earn their way and then you don't get rehired the next year. I mean, your job depends on your ability to make the bottom line, make enough money to pay for your position. It's a business, you know.
Yes.
Yes, it's a business, and they have to make money to have you.
Yes.
Know? So,
or your ancillary staff, if you have a medical assistant, you need to bring in enough to cover your medical assistant
right.
too.
And there's office expenses, and there's, you know, there's overhead that you're part of. So then there's a difference in the primary world. The office is a whole different environment, and the way it runs is a whole different environment than the hospital. And that's sometimes a transition for RNs who are now used to working in the hospital all the time. Now they're in an office setting, and it's just run completely different.
It is. There's a lot to learn about how the office works, and the patients. It's very different to take care of a chronic illness versus just an acute illness. So in the ICU or even in the hospital, I have patients, it's a short time, they're better, they're gone, that's it. I may never see them again. Sometimes there are repeat flyers, you know, people that come back and readmitted. But in general, it's a few days with me, they're gone, and that's it. And so working in the office, you start developing relationships I really valued. It's something I didn't know I was missing.
Yeah, it becomes something that you get to know mom, you get to know dad, you get to know cousins, you get to know the history, the challenges, and you get to do things that, you know, that are very touching, and you can really celebrate successes with patients, but you also are the bearer of hard diagnoses too.
This is true.
And so that's another aspect I don't think we as RNs are prepared for. We're used to being that person that is there to listen after somebody has told somebody the bad news. But I've had to tell multiple people they've had cancer and go over those test results and what the next steps are. And it's just a hard thing to do. And I know in the pulmonary field, you have to, because lung cancer was my highest. You know, cancer.
And especially with lung cancer screenings we do. So it's a little different in the hospital. Something has brought that patient to the hospital where they're not feeling well and they know something's not right. And you come across it, it's still hard news to give, but it's sometimes almost anticipated. There's something going on. But sometimes in the office, that's not what's on the radar at all. That's not what's anticipated. Maybe they're just doing their screening because they qualified for their lung cancer screening. And then what you discover is more than a nodule. It's a big mass, and it's a stage 4 situation. And that's
how, you know, when you first see that, before you even talk to that patient, I know the way it works for me, it just grips you.
It does.
It's like, oh my gosh, I'm going to have to bring this news to that person.
Right.
How am I? And you think about it all day long. Usually you try to schedule it at the end of the day or at a time when you know you're going to have time to sit with that person and go over their questions. But it weighs on you more than, those were some of my toughest moments.
I would agree. And when, you know, those relationships I talked about those are special relationships that you develop with your patients. And so, you know, that's hard. You've had this relationship, and then you're going to go through this together too, but sharing that news with them and their family and
then watching the progression, because as that primary care provider, I always tell my students, don't worry, if you get it wrong the first time, they'll be back. You know, and if you get it wrong the second time, they'll be back, you know, and you'll have to figure out what is my next thing I'm going to try, you know, because this didn't work or that didn't work, right? And if they've got a hard diagnosis, they're going to get sicker, or, you know, you're going to go through that journey. They may see the oncologist and everybody else, but they're going to still be coming to you for, you know, their regular routine care, and you're going to see their decline. And sometimes you might be there to hold their hand when they finally do pass, because I know I've made those calls where I've gone to their house. And
it's hard because you're going into this field in this career, hopefully, is because you want to help people and you want to better them. And when you get a hard diagnosis, and no matter how much you want it, and no matter how hard you're willing to work for it, sometimes the outcome that you want is just not in the cards. And it is hard to
be that person.
It is.
Know it and to know what's coming.
And to have those conversations that we've reached a point that there's not much more we can do. It's out of our hands now. Those are really hard conversations because especially if the patient's not at that point yet, that mentally that they want to accept that.
Well, in this last year, you had the opposite effect too. I mean, you had experienced that with a family member, and being the NP, not just the nurse. We know as the nurse, your whole family reaches out and always asks for questions. And if you're an NP or a provider, it's even more.
Yes.
And you've got a broader understanding of where the labs are going and where it's pointing to. Is it going in the right direction or is it going in the wrong direction? And this time you were the daughter. And
yes.
So that was a whole new experience for you.
Yes. We had my father somewhat unexpectedly became ill, very ill, and hospitalized. And this was also during the time of COVID, which made it very challenging. He did not have COVID, but it definitely affected our experiences. And then being a healthcare provider and a daughter, your roles get muddled because you're not able really just to sit there and ignore the labs and the x-rays and say, I'm just going to be a daughter today. You can't do that. And the care providers there in the hospital also rely on you because they know you know this person better than anyone, and you can give them the report and the information they need better than anyone. So you become very involved in their care to a degree, although you're not managing it. You become very involved, but that's challenging. That's challenging when you also need to balance that part that this relationship you have with my father, in my case, just being a daughter and trying to set those things aside and just being a daughter during that time.
Well, and then like you said, with COVID, we've had all of this isolation, and that's really been hard on families. It's been a year like none other. I've watched people in the hospital get sicker and get better because family was able to be more present. So, I mean, and it's very muddled as to when, depending on what hospital you're in, when they'll allow visitors to come in after a COVID diagnosis, if ever, and they have to get, it's just a very mixed up time. We don't really have clear guidance from one place to another as to what they're doing.
And I definitely see the toll it takes on the patients. I mean, I see it firsthand. I saw it firsthand in my experience. When my father was in the hospital, he did pass away in the hospital. But while he was hospitalized, they had just started allowing one visitor. You could designate one visitor for your entire stay. There were certain hours they could be there. If they left the hospital, they couldn't come back that day. Very strict. You had an arm bracelet, got ID'd and checked every day to make sure you were the visitor. So with my healthcare background, I was the visitor. But and I was thankful to be there. And I thought about everyone before him that wasn't able to have anyone, or the people with COVID that could not have anyone. Because we talk about FaceTime, and FaceTime is a great tool for a lot of things, but there's just no touch. There's no substitution, for human touch. And especially if somebody is in a critical care situation, or they're scared, or they're facing the end of their life. Sometimes just holding their hands and no words is more powerful than a FaceTime conversation ever could be. And that touch of their loved one is really important.
And it is that touch of the loved one. I mean, I know that we have made healthcare workers have to step into the role of that loved one, because you would see those people being in those rooms isolated, scared, and your heart just goes out to them, and you want to show them. But to have a loved one to be able to say, come on, take a bite of your soup, or could you drink a little more water, or they'll do a little more for that. It's isolation that I've watched this year as bad as COVID has been, I think the isolation has been devastating.
And it's tough to know the right answer. I know that there was worried about appropriate equipment and protective equipment and that shortage, and I hope with the encouragement we're seeing with the vaccines and with people that have had
we have
COVID.
therapeutics too now. We do have therapeutics now that
Yes.
do work. They really, if they're given appropriately and at the right time, we know how to treat it so much better. So we're definitely on the hopefully better outcomes. I'm certainly seeing better outcomes. I don't know about you, but definitely it's been a hard year for nurses, for physicians, for patients and patients' families.
Mm-hmm.
All told.
Absolutely.
We've covered just a slew of stuff. Is there any words of wisdom or advice you would give to a new NP coming in, scared to death, especially as their eyes are being more and more opened to the role they really are getting into? What would you say to them?
I would say a small amount of fear sometimes and anxiety is healthy because it propels us to do the work that we need to do. And so, and I would tell them that it's going to get better, but to understand that first year is going to be, I think no matter where you step in, it's a new role, whether it's not just a hospitalist role. If I just stepped into that pulmonary office, there's going to be things that are different than you've done before. But just to understand it's going to be difficult. It's going to be a lot of hours. It's going to still be a lot of studying. You have not finished learning. And
definitely, I agree with that.
It's going to get easier.
Yes.
So to hang in
right
there,
at the end of the tunnel,
easier.
Hang in there, build things. I would say too is build those relationships. Like you said, you really built those relationships with the ER docs and the ICU docs, your specialists. They're your right-hand people. Reach out to them.
Your nursing staff, your medical assistants, everyone, pharmacists, everyone that is a part of the team. I think, hold them with value and treat them well and build those relationships. It's just, it'll help you with your patient outcomes. It'll help you with your day-to-day
and
job.
Ultimately we'll get, like you said, safer, better care.
Yes.
Because if you do have a question, you haven't lost the network. I think they feel like, well, I had this network of nurses around me in the hospital and I could just call the charge nurse, and now you still have a network. You're alone and you're functioning autonomously in a way, but you still have a network. It's just more by text or, you have to go somewhere, call someone to get those answers.
And it's important to build that confidence. And my other advice really is to find your voice. And you're in a position now you can't afford to be intimidated not to ask the question when you need to ask the question. And there's different personalities, just like anywhere in life. We're going to come across different personalities, but it's really important to find your professional voice and to stand up for your patients, and not be afraid to ask the questions.
Well, I appreciate you coming on again and giving us your words of wisdom. Adina, we really value what you're doing in the world of medicine, and I wish you the best of luck in your career.
Oh, thank you. Thank you. And I appreciate everything you do to promote our profession. I absolutely love what I do. It's so much more than a career.
It really is. I guess that would be our last words is it's worth it. It's a difficult journey, but it is worth it. It's where I want to be and
absolutely
doing what I want to do, and the outcomes that are good just lift you so high, and the ones that aren't as the outcome you would want it to be, you learn how to help families cope with that loss too, and you kind of travel that road with them. Thank you so much. Thank you all for listening. Thank you for joining us for this episode. And join us again next week for more NPs with insights about their practice. Bye.